An intraoperative hard eye during phacoemulsification is characterized by raised pressure, progressive shallowing of the antechamber, and is an uncommon condition. But it's quite distressing for the surgeon when faced with this situation. The two serious causes for this phenomenon are the fluid misdirection and suprachoroidal hemorrhage. Of course, external pressure sources like tight speculum or a drape, tight lids, etc. are common but easily correctable. Fluid misdirection causing hard eye is specifically named as an acute intraoperative rock hard eye syndrome. The incidence of fluid misdirection is significantly more common than the suprachoroidal hemorrhage. But in the event of an intraoperative hard eye, is it possible to differentiate between them on the table? Among all these features seen during an intraoperative hard eye, the red fundal glow is thought to give us some clue. Is it so? Let me take you through few of my experiences. A patient with phacomorphic lens-induced glaucoma and pseudoexfoliation is on anti-glaucoma medications posted for surgery. The pressure is 12 just before the surgery. As the dye is injected into the eye and is irrigated out with BSS, the eye becomes hard, AC is shallow, and OVD is injected to deepen the chamber but in vain. Now, since this eye hardened immediately after injecting fluid in the antechamber, and this was an eye with loose zonules, my thought that this could be fluid misdirection because fluid has an access across the weak zonules into the burger space, which is creating this shallow chamber and a hard eye. A pars plana tap let out the dye-laced fluid from the burger space and the eye dramatically softened and the surgery is completed with ease. The next case. Now, this is an elderly male patient with pseudoexfoliation undergoing phaco. After emulsification of the nucleus, the antechamber shallows and the iris is being pushed out and the eye becomes hard. The red glow continues to be good, however. As this was a case with again loose zonules, I was anticipating fluid misdirection to happen. We aborted the surgery temporarily, started him on IV mannitol at the table, and after 20 minutes the pressure had significantly reduced. The surgery could be performed with relative ease with good outcomes. The third case. A healthy 65-year-old lady undergoing a routine phaco for toric IOL implantation under topical anesthesia. Apart from the cataract, she does not have any ocular pathology. Her IOP is 16 preoperatively on the day of surgery, as were her other vitals. The surgery seems straightforward. Rhexis is done, nucleus emulsification done. Surgery is going on in a very predictable way until now. I'm doing cortex aspiration, things are looking alright, but as I'm trying to perform hydropolishing to remove some fine fibers, I notice that the eye is becoming hard. The chamber is shallowing, the posterior capsule is literally bulging anteriorly. I hydrate all the wounds and wait for about half a minute. The patient is complaining of slight pain as I'm trying to push in cohesive OVD into the eye to deepen the chamber. Well, this is a dramatic visual. The OVD is refusing to get in. Such is the pressure from within the eye that more OVD is gushing out than I can put in. There's absolutely no space in the capsular bag. The positive pressure is relentless. Please note the red glow continues to be absolutely fine. At this point, I am hitting the pause button for a couple of minutes. Fluid misdirection versus suprachoroidal hemorrhage. The great debate is going on in my head. The fundal glow is excellent. The patient is healthy, no glaucoma, it must be fluid misdirection, I thought. After 2 minutes, the situation did not improve. If it was fluid misdirection, there should have been some reduction in the pressure. This got me suspicious, I aborted the surgery. Indirect orthoscopy, view is not clear because of the corneal edema. The posterior pole looks alright. My technician performs B scan and the central scan is normal. I thought this is a fluid misdirection. Patient was given IV mannitol and the patient was shifted back to OR after a couple of hours. Situation is mildly better. I implant the lens with some difficulty. The eye again becomes hard and I am unable to proceed. Since I have a good red glow and the B scan is normal, I was still thinking in terms of fluid misdirection. I decided to perform pars plana tap, but nothing comes out. It was a dry tap. Well, this was a serious concern. A moment of panic. I closed all the incisions. Back to the ultrasound room. Gingerly I monitored the B scan being performed. The posterior pole scan was still fine, however, as we began scanning in the peripheral areas. This is what we found. There was clear evidence of suprachoroidal hemorrhage. It was restricted only to certain areas. And this was my first encounter with suprachoroidal hemorrhage in the last 20 years of my practice. These are the first day post-op pictures. This corneal edema, the antechamber was still shallow, but the pressures had come down. The patient was treated with anti-glaucoma medications, topical steroids, systemic steroids, and atropine. And by the end of 1 month, the scans were normal, the suprachoroidal hemorrhage resolved, and the patient had a best credited visual acuity of 6.6. Masterly inactivity, conservative management, along with loads of prayers. This was all that was done, and the patient miraculously improved over a period of 1 month. This is the last case, a 75-year-old healthy lady with no ocular or systemic condition. The features of intraoperative hard eye appear after IOL implantation. The AC is shallowing profoundly and the eye is hard. I cannot position the lens appropriately, the pressure is relentless. I close the eye. B-scan again reveals a normal posterior pole, but the scans in the peripheral quadrant show choroidal hemorrhage. Management would be the same, prayers and medical management to control pressure and inflammation. By 6 weeks, hemorrhage resolved completely and the eye looks fine. So what did I learn? Although the incidence of fluid misdirection as a cause for intraoperative hard eye is higher, limited or aborted suprachoroidal hemorrhage is not very uncommon. In our series, 0.04% was the incidence. As demonstrated in this film, intraoperative diagnosis of a limited or evolving suprachoroidal hemorrhage is quite challenging. In the 2 cases with proven suprachoroidal hemorrhage, there was excellent red glow throughout, as it was seen also in eye with fluid misdirection. Hence, relying just on the presence of a good fundal glow to rule out suprachoroidal hemorrhage intraoperatively would not be a wise thing. In our experience, a thorough B-scan evaluation is the best technique to establish the diagnosis. It's important to remember that limited suprachoroidal hemorrhage is seen in the peripheral quadrants, hence we are more likely to miss it if we scan only the central pole. Pars plana needle aspiration of fluid from the Berger space is a recommended treatment modality for fluid misdirection. However, differentiating fluid misdirection from suprachoroidal hemorrhage intraoperatively is difficult. Hence, attempting a pars plana needle aspiration, assuming it to be a fluid misdirection in an eye with suprachoroidal hemorrhage, could be disastrous. So the bottom line, in the event of an intraoperative hard eye, one should be mindful that there could be a wolf hiding in the herd of sheep. The moral of the story, differentiating fluid misdirection from a limited or aborted suprachoroidal hemorrhage is very difficult. The presence or absence of a red glow may not be the best sign to rely on. In suspicious cases, it would be best to abort the surgery and do a thorough B-scan evaluation to rule out an limited or evolving or aborted or an impending suprachoroidal hemorrhage. Although it's more glamorous and heroic to do a pars plana tap to drain out the fluid in the Berger space in a case with intraoperative hard eye, this case taught me something else. Well, it taught me that being conservative is more sensible in such a situation. Thank you.